media labs in Dublin. And so we built out this set of fictional products around thinking about what would be artifacts that would trigger behavior, that would be contribute to well-being and to health. So this is gum, that you get your little gum calendar. If you want to know if you're falling in love with someone, you buy the love gum and you chew it every day, and it changes color based on whether you're falling in love or not. And it was funny, it's very tongue-in-cheek, but every time we built out these sets, we based it on the principle that we're reading. We did a lot of reading in the sciences about what's happening in medicine, and we discovered that someone had said they identified this enzyme. When you fall in love, this enzyme is really easy to trace in saliva. And so we're like, oh, that's a really good thing. So we could just make gum, and then you know if you're falling in love or falling out of love. So again, I don't know how many of you know that kind of idea of fictional products, where you just kind of, the product becomes the kind of proposition. We imagined simple things as the same could happen with toothpaste, where you could track fertility, you could track obviously alcohol consumption, you could track a lot of different kind of biochemical conditions through a simple domestic object like toothpaste and toothbrush. Same with this. We then turned and looked at, well, what are the well-being potentials of phones, and we thought it would be really interesting that we had heard about this idea of tracking frequency and phrase and tone and inflection, and you can tell when someone's lying. So we thought we created a loaded lying software onto phones. And every time you came out of a phone call, it would tell you how many times you had lied. You just look at the screen and it would say 27. And it wouldn't tell anyone else, but we were thinking about this whole kind of thing that objects that appear relatively benign and kind of dumb have the capacity to be really powerful and to really play an active role in this. And so we thought, well, it's really easy software, and if you speak into your phone and your mom doesn't have to know that you lied 27 times to her, you could get a bill then at the end of the month, and then you could check how many other people that you've been lying to and the frequency, and then you could worry about what you were becoming. We then designed this phone that had this like strip, a galvanic phone, that if the galvanic moisture in your hand got to a certain level, which was usually an indicator of rage or excitement, the phone would shut down. So I mean, it's totally tongue-in-cheek, right? But it was just as a kind of, I had hired some designers to work with me at the lab, and we really wanted to understand what happens when designers look at this area of health and well-being. So that was wonderful, and it was very creative. Inside the belly of the beast. I don't know how I'm doing on time, but I'm going to move now and tell you a little bit about Mayo Clinic. So I joined Mayo Clinic 3.5 years ago. Mayo Clinic is here. Rose is here. Rose? In the back. Okay, so she's proof that we do exist. So I have Rose up there, who is one of the design researchers that I work with. I call it the belly of the beast because I think it is, you know, having gone from design around the body and for the body and being intrigued by it and kind of being suspicious of the science of it, of how it is deconstructed. It was pretty remarkable, as Samantha said, to actually go into a clinic like this and to kind of see how it functions. What you learn first when you go into a place like Mayo Clinic is that it's a scientific environment. Scientific research enjoys total credibility as long as it declares the questions it's asked to seek to answer. You only see what you're looking for and are limited further to the places you choose to look, and you only answer the questions that you ask. This was a bit of a surprise to me. Most consumer market-driven industries have been leveraging design extensively, understanding that at the core of innovation is creativity, and that creativity is a kind of elusive skill taught to a rather obscure group of individuals called designers. And design is a vocation-based practice of creating something from nothing. Service or system design, which is what we do at Mayo, is the practice of moving from complexity and fragmentation to clarity and a lot of interconnectedness. Okay, so this is us. Not all of us, but this is some of us. Rose is right. I can't. She's not wearing that today, but we're all living in Rochester, Minnesota. And we have to wear stockings now that we didn't ever have to wear before. So just it's a group of designers who wear stockings to work. And it's been a remarkable place to work. There's a tradition definitely at the clinic already of design, and there's a history there where a lot of the artifacts, the medical equipment, the medical artifacts that existed there were commissioned by the different surgeons. And so there have been moments where design has played a really important role. This is a chloroform inhaler that is in the museum at Mayo. And what's so beautiful about it is that it's that kind of form function where it's a really elegant shape. It's made for a physician, for a surgeon, but then the level of decoration, it's being decorated and it's being kind of elevated through the use of really expensive inks and paints to really speak to this person's status as a surgeon. So with all these beautiful artifacts, still, we kind of re-encounter them every now and again as aspects of design. This is what's happened in design in Mayo for the last 50 years. This was an example in 1954, and this is an example in 2004. So there's a lot of design going on in Mayo Clinic. And it's not, it's a massive organization. We see 1.1 million patients a year, so just over a million. And we are 58,000 employees. And so, not to be flippant about this, but this is a huge organization, so change is really, really slow. I'll give you an example of the scale. It started out in 1900, and there was 10 departments. Then those departments got kind of split into subspecialties. So you had things like internal medicine, so you can see internal medicine then was split and became all of these different expertise. And this is what's happened in general in medicine. So in the last 100 years, medicine has just become so fractured. And it's probably one of the reasons patients find it so hard to navigate is that it is becoming more and more of a kind of it's a network system of it's a very elaborate network system. And to navigate your way around it, even as a professional, is impossible. So this degree of growth and this scale of growth for one institution has been pretty extensive. We also have not just one kind of patient. We see a lot of different types of patients. They're complex, chronic, procedural, simple, and annual well. So complex is often they're undiagnosed, they have a medical oddity. There's several intertwining conditions requiring multiple specialists. The chronic is a little bit more under control. The chronic might be something like diabetes. Procedural, someone's coming to have a hip done, they're coming for a transplant, they're coming to have a stent. A simple patient is a patient that only has one condition, and then the annual well of the patients that are just coming back to check in. I wanted to share with you this really beautiful composite that a physician that we work with made to describe the complexity of one patient. So I'm trying to build a story of levels of complexities before I can show you what we've been doing. So this patient was 55, had diabetes, was on metformin, had hypertension, took beta blockers for that, got dizzy from the beta blockers, had high cholesterol, and had depression. But was also obese and so had back pain and neuropathy, which was pain in his feet. So he went to an endocrinologist, a podiatrist to look after his feet. He was to do this, he had to take time off work, get a ride. He was told to avoid salt, fat, carbs. He was told to exercise, to check his feet, even though he couldn't see his feet because he was obese and he used to have to get his wife to check his feet. The thing about with diabetes, I don't know how many of you know, is that the nerve endings die in diabetics, and so their feet can get injured and they don't have any feeling in their feet and they can get very infected. And so frequently when you have amputation with diabetes, it's because of an infection that you weren't able to detect because the nerves die off. So all these things have to be checked. Had to check his sugars and keep them low, and his weight. And he was in pain. And in pain and he couldn't sleep. So this is the patient's experience. This is one patient's experience with one disease. He also had been 3 and then 2 and then 1 of accountants in a firm. They'd been let go. He was the last one. There was always deadlines. He always had to perform. He took work home. Numbers never added up. He had to work. He needed to work to keep his insurance. He was already in debt and then not able to pay the mortgage. His daughter came to live back home. She brought her 2 daughters with her. But the sad thing was that she had a bad dependency on alcohol, and she was there with the girls who didn't look after the girls. So this was a composite that was made by one of the physicians describing a patient and the level of complexity that one patient can present in terms of all the different conditions and all the different determinants of health. So this is Rose. This is not Rose who's sitting up there. It's another Rose. This is what happens to patients when they come into the hospital or can come into the hospital. I don't know if this animation's going to play. Let's go back. It's pretty slow. So Rose is the dot, and this is the period of 48 hours. Rose is in the hospital. This is what happens, her acuity. She has an infectious disease, she has nephrology, she has cardiac issues, she has neurology issues, and then respiratory issues. All of these things will happen at the same time. This is Rose again, in the hospital, 48 hours. These are all the other people, These are all the other people who are in the same unit with her. What's interesting here, if you track the purple dot, which is Rose, relative to the blue dots, which are the other people that are in the ICU, at the height of her acuity, which is the second dot, and she's at the height of her risk and need, she's the least sickest person in that ward. So she's getting the least amount of help. So now we have the compounding factors of complex systems. We have complex patients, multiple ones of them, and then we have complex events and the way those patients play out. So healthcare has been really interesting as a designer because it teaches you just how incredibly complex a system will be and the moving parts of it. So when we as a group encountered this, I think one thing we had to do is we had to really we had to understand the nature of how we could function inside that complexity. So in the beginning we looked for similarities. We looked to appear familiar and rational and logical and methodical and even scientific. We built maps of our process to mimic those of scientific research. We made incremental progressive inquiry. We focused methodically. What we didn't do is we never spoke about the huge leaps of imagination that drove our work. So when we were asked to build out a map showing the way that the designers think and work, this is what we built. We all simplify things for convenience. It's human nature. We imagine we need to simplify things if we're going to collaborate, to find a common ground, a shared language. I think it was so important to us that we could collaborate with the scientific community at Mayo that we really wanted to not be pretentious and precocious in any way, so we really wanted to dumb down our process. We knew that humans have a strong bias to cause and effect, and that makes very direct linear connections, a way of explaining things. Our minds create a narrative to explain what happens, but in complex systems, the cause and effect are not easy to understand. We also understood that as people become experts, they direct their energy towards reinforcing what they already know rather than exploring new things. They circle around a topic, looping back to it, and rarely diverge from it. This is true both of science, but it's also true of design. We ended up using this graph to explain to people what we did. It just seemed simpler and easier to explain this way. These drawings are drawings made by the few designers at the time, just explaining what they really felt the work was like. And then this one that we all decided was the most accurate. That was like our guilty pleasure. So being embedded inside a clinical practice is really, really a unique experience. And again, just describing the level of complexity to you, there's moving parts, it's quite intimidating. But we did begin to understand things differently. So science and medicine are full of great leaps of imagination also. There's hypotheses, there's theory, and followed only then by more logical, rational inquiry. We learned a lot that you can never confuse knowledge with understanding. You can know something without fully understanding it. This was something that one of our designers discovered when she asked a physician about a medication and how it worked. And he said, we don't know how they work, we just know they do. And many of us have been testing that by asking other physicians, when we see them practice, how they know something works. And the response is usually, we don't know how it works, we just know that it does. Every time we understand something, it reveals so many other things that we still don't know. And every time we think we understand something, we only understand it from one perspective. The opposite could be true. We ask questions to remind ourselves of what we still don't know. It's an essential role of design to draw attention to the gaps in the story, and I think this is really a huge part of why we're at Mayo, is to draw attention to the gaps. What matters is not what's true or what can be proven, but what is possible. Truth is limited to just what we can agree on. And so it can only describe the present state. So we all know the future will be created through imagination. I know I've got lots of text. I have more pictures soon. Sorry, but I love this. I found this description of imagination and it was wonderful, so I'm going to force you to listen to me. Imagination is not only the unique human capacity to envision that which is not, and therefore the fount of all invention and innovation. It is arguably most transformative and revelatory capacity is in the power that enables us to empathize with humans whose experience we have never shared. Unlike any other creature on this planet, the human can learn and understand without having experienced. They can think themselves into another person's place. I think that's like the most important description I've ever heard, or the best, of why imagination is so important in design. And that it's not gratuitous and it's not fluffy, it's actually something very focused and very powerful. So at Mayo, I think we've been trying to get the general population to think beyond what's always expected and to kind of open up their view to think about things they never dared to imagine. So here's some work that we do and how we work. We typically approach working with the departments, working with patients, and we like to build our own tools because we kind of spend a lot of time in clinical practice doing a lot of observing and shadowing and working with patients, working with the clinical staff, but we know that the time is really valuable. I mean, if they're with us, they're not with the patient, and so we have to be very careful to really optimize that time. So we've become very skilled at building tools that kind of capture what we're doing and also do a level of synthesis in real time. We use personas a lot because people talk very generally about the idea of a patient, and so we like to have segmentation with groups when we talk about their patients. We make the invisible visible, and we create compelling evidence for change. And so a lot of what we end up doing is being able to visualize what's happening, the dynamics of what's happening in the hospital. This particular example is just calling out what's heard but not captured in an OR. So things that are being said that are critical moments in the surgery that are being said but not captured anywhere, and that's a real problem because then not everyone gets to know that something's happened. So there's some very simple things like that we call out, and we have to then create new protocols in the surgical suite to make sure that what's said is captured. This is an example of just making invisible visible again, tracing the path for all these different people working in a surgical suite, and kind of really helping to expose so many of the kind of gaps in the system. Design helps to make better decisions. I think if you visualize something that's really complex and people can look at it, then they can make much better decisions about how to improve it. And in the absence of having something to look at, it's really, really hard to get consensus about what's better. We bring meaning and understanding to data through its relationship to other data. We like to make things, and we're all designers, so every time we get to make something, we sit down and really quickly prototype. It's part of what makes us most effective at Mayo is we do that. Okay, that's my duck. Okay, I'm gonna. I actually have a way of sounding like a duck. So I wanted to finish by hopefully not being arrogant to tell you I think I have some interesting ideas about the direction that design is going and wanted to share them with you. Hopefully they'll be meaningful. And now I'm going to have to remember them because they're all half written on the screen. So we've tried to find control and change, and we build tools in search of control. So this was a big kind of revelation for me recently. I was thinking, we work in the area of innovation, and I think, innovation is always about, making things better, and it's about change. And then you realize that people want you to innovate because they're scared about the future, and they want you to control the future. And so innovation is really about control, and change is often about control. Like, if people say they want to change something, they often want to change it because they want more control. This is going to be really hard, I can't remember. Move from believing that problems are solved. X. Okay, I got it. This is one of my favorite ones. I'm going to do this right now. That's it, because it's got a big word there. Move from believing that problems are solved by eradicating the problem, okay, and then move to imagining an alternative future state that makes the problem obsolete. I think this is a really key thing to remember is that when you're looking at really, really difficult problems, don't focus too much on trying to get rid of the problem. There's no eradicating massive problems. You have to figure out what you can do to create alternative models that then that problem just becomes obsolete. So don't spend too much time even trying to understand how big and hairy a problem is. Design is no longer about the finite and the absolute solution, but it's more about a process by which people can move from what they know, from the known to the unknown with confidence. That's certainly what we do at Mayo. I think it's a lot of kind of creating pathways and capacity for people to try and move out of their comfort zone. Design is one of the most effective ways to affect behavior. It's far, far more effective than fear, intimidation, or coercion. And I think that's a really important thing to remember when you think about all the places socially that the other forces are attempted to use to control behavior. Design is the most effective. Designers are diagnosing society and they're prescribing solutions, but our diagnostic tools are pretty unsophisticated. We really feel this at Mayo. We really feel that we need different, more robust, more elaborate tools to do our work. People are asking us to tackle bigger problems. We need new tools to do things at scale. It's no longer enough to study a handful of individuals and then just generalize. And research, too, has its limitations. It's too precise an activity to effectively address the challenges of complexity. By virtue of being reductive, it excludes and isolates so as to examine and to understand. And again, it creates a false sense of control. So the work we do, I watch my group, I watch myself, and we ultimately are reductive in what we do. And it's very, very challenging it's a system that's so complex to say with any conviction and honesty that any one thing can be understood and fixed without the impact of it just, the whole system gets impacted. It's important to know what you can affect and what you can't. I think in design in general, that's really important. This is something I discovered pretty early on. I had just arrived at Mayo, and I really wanted people to understand designers because they kept saying, what are designers and why are you here and do you make cushions and drapes? And I was like so outraged. I'm like, oh, you have to understand us. And I went around being outraged and outraged rather. And then people said, well, if you're going to go around being outraged, it's just going to be irrelevant because we don't really have much time and we have a lot of outraged people already here. So, and then it really struck me, I don't know what I was trying to prove. I think that what you don't need to be understood, you need to be valued and you need to be relevant. So don't worry if people can't describe back to you what you do, just make sure you're being relevant. Our value can be assessed by asking, what did we add? What did we make? What did we make better? And how do we know? These are the most important questions. How did you make something better? And how do you know you made it better? Or do you just think it was better because you really liked it? Who will determine our futures? This is back to that big question about what's the future of humanity, which I'm still worried about. I think the work that we've done in the clinic is to have a design group working so closely with scientists and the medical profession. I think that those relationships become so important. So when you think about who will determine our future, design needs to forge partnerships so it can have influence. And that's what we're doing at Mayo. We're just trying to have influence. And I'll leave you with the last couple. I think really interestingly, outside of the area of healthcare, a challenge to designers to think about what are new models of fabrication and new habits of consumption. In general, we have to rethink products, we have to rethink consumption, we have to rethink exchange, we have to rethink value, and we have to rethink design. This is my favorite quote. We're continually faced by big opportunities, brilliantly disguised as insoluble problems.